grandfather graduated from medical school in 1933 from the University of Maryland, Depression. And he was a poor guy, and so back then the way that you put yourself through med school was the state would say to you, if you want to practice and you want us to pay for your medical schooling, you owe us a certain amount of your life. And here are the places you could go. Coal mining territory in West Virginia, somehow that was part of Maryland at the time, I don't understand that. Or Ellicott City, Maryland, which was a little rural town, which is now an artist community, is basically part of the Baltimore suburb, but back then it was in the middle of nowhere. And so my grandfather lived into his 80s. He got married when he was 21, my parents got married when they were 21. So my brothers and I'm one of 5 boys, 4 of us are medical doctors. We all got to know Granddad very well. And he actually watched us all graduate from med school. And he got paid in chickens and corn during the Depression, or lilacs if it was May. And in nothing, people couldn't afford it. So we were raised with that ethic. He was a wonderful guy. Everybody, he could strike up a conversation with a total stranger and get to like him in 2 seconds. And so we all grew up wanting to be like him. And so that's a big part of why I am who I am, because, you know, I can't reproduce the Depression, but I'll tell you, when you go to Nicaragua, you feel like you're back in the 1930s with horse traffic going back and forth in front of you, just like what his life was like. The other part of it is the ethic that I was raised is that my responsibility as a human being on this planet, especially one who is lucky enough to be in this country, is to remember, first of all, where my people came from. Because these people that I see in Malawi, the ones I see in Nicaragua, the ones who take care of the soup kitchen that are dirt poor, those are my people once upon a time. They were all our people. We all came from those roots. Sometime in the future, maybe some of our great-grandchildren will end up being poor again. Who knows? So I feel an obligation, and I've always felt it, to give back in some way. And to be grateful, and not just take advantage and take for granted what we have, but to actually live the fact that since we're blessed by living in this country with all of this wealth and all of this wonder, that we should be careful to take care of those who aren't blessed, because everybody should. So I could go on and preach, but I won't do that to you. I do want you all to memorize this picture, because it will reappear at the end. This is actually the beginning of the talk with your hands. Actually, Cindy, do you want to operate the, so that I don't have to turn around and show people my side? So, and I should say, she runs the Agape Cafe. So she's the brains of the outfit, and I just do whatever I'm told. So it doesn't knock you for the credit she deserves. So we tell people that she's the local and I'm the global. So I'm on the Tufts Medical School faculty, but as I said, this is not an official part of the Tufts program. So we are basically now a nonprofit that we started. There's another orthopedic doctor and an emergency department nurse in Sydney. The 4 of us were the entire nonprofit. And it's based on the idea that we would like to do whatever we can to help and allow. Now, when I first agreed to give this talk, the idea was to talk mostly about imagining malaria. So I have been given permission to talk a little bit about styling as well. So I want to make sure that you get both messages. Next slide, please. So this slide may have changed a bit because I hear Imagine Malaria is changing a little bit about what they're doing, but that's basically on their website from a few months ago when I first wrote the talk as to what happens if you give them money. And I believe that their number is $7 a person is what they're looking for. If you want to think about that, it's kind of, I don't know how much Dunkin' Donuts costs now, but it's probably, between that and Starbucks, if you gave up a cup of coffee a day, you would be helping one person if you took that money and put it towards Imagine Malaria. So this includes things like prevention, treatment, includes nets, or at least it did. I don't know if they're still doing that. They're still doing it? Yeah. It includes malaria testing. It includes treatment. It includes education. And so an awful lot of different things. And this is being done all over the world. In Malawi, they're not doing it there because there's some politics involved in this. This is the American United Methodist Church's push. So wherever there is an American...
Sub-Saharan.
Right, but I think in certain countries where there is no presence of the American United Methodist Church, that's my understanding, they're not involved, and it's not their choice, it's the choice of the government there. So Malawi was a British colony, and I don't think the American Methodist Church is a present there, it's the British Methodist Church. So, next slide. Okay, so we're going to talk about malaria. Next slide. So, wait a second, just where's Malawi? Okay, now don't push any buttons yet. How many of you in this room were Malawi? Don't just say Africa, because that's cheating. You actually know where it is? Yeah, and you'd be cheating too, because you're from Zimbabwe. You know where it is?
Generally, kind of like in the above South African.
Yeah, very good. I'm impressed. I didn't know where I didn't know where it was. Okay, next slide. There it is right there. So it's a tiny sliver of a country. It used to be known as British Nyasaland, and it was next to Northern Rhodesia, British Northern Rhodesia, British Southern Rhodesia. So Northern Rhodesia is Zambia, Nyasaland is Malawi, and Southern Rhodesia is Zimbabwe. And this other country is Mozambique right here, with Madagascar out there. Next slide. Okay, what we need to talk about malaria. So why do we care about malaria? Okay, so you guys are what's called a selection bias. You're here because you're already here. But let's take the average person out here. Yesterday I was getting my oil changed. The guy said to me, what are you doing tomorrow? So I told him what I was doing, and he said, you can't wipe out malaria. It's everywhere. It's always going to be there. So why even bother to put the effort into this? So let me start by asking you this simple question. Was malaria ever in the United States?
My grandmother was on her honeymoon
Where was she?
in the, I think they went to, they were going to Detroit, California.
Okay, so that answers the second question. I knew it was in the United States because I'm kind of a history geek, but I thought New Orleans, you know,
DC.
Biloxi, DC to some extent, but more in the southern part of the country. Nope. There's the map. So this is 1882. Every place you see hatched in there, there was malaria. And the reason it stops at the Canadian border is because this is the CDC for the United States. We're not in Canada. So that includes Massachusetts. So it was a huge area that was affected. So the next time any of you run into a libertarian who says the government doesn't do anything, you know why that map is empty now? Because the government fixed that problem. So that's an example of your government at work. And it's also proof that it's not a hopeless problem, that it's not an insoluble problem. Even though it feels like it, it's not. Okay, next slide. So that's a CDC slide that just shows the number of deaths per million population, number of cases over from 1920 to 1946 for malaria. And this number is 400 up there, it's 2 down there. So is there still malaria in the United States? Actually there is. It's extraordinarily rare, and almost nobody gets it from living here and being bitten by a mosquito that came from here. You get it because you travel to Malawi or to Brazil or some other place where malaria still exists. You got it there, you came back, and then you got sick here.
Can you describe what the symptoms are?
I'm getting there.
Oh, okay.
One step at a time, don't rush. Next slide. You can probably describe it because I bet you've had it, haven't you?
It has, but not.
Okay, so these are today's statistics. Over 1 billion people worldwide are infected. So again, that's a huge number. Sounds like this is an impossible problem. Now the flyers that say that are imagining malaria that are right here, see where it says malaria deaths cut in half? I actually went and looked that up to see if that was true. And before I looked it up, I said, maybe I should change my slides. So I did change my slides. When I wrote this talk in 2003 to give to high school kids that are part of the contest that I run for this whole program, because I take high school kids with me as part of the medical mission trip, that number was 2 billion. This number hasn't changed. 3.4 billion people live in areas of risk of malaria transmission. So if you figure that there are 7 billion people on the planet, 1 out of every 7 people has malaria, and 1 out of every 2 people is at risk of getting it. And 207 million new infections every year. This actually was at least double that back in 2003. So these numbers have in fact changed for the better. Now, I'd like to take personal credit for that, but it's not me. And I don't think ELMCOR can take personal credit for it. I think you have to thank the Gates Foundation, the Carter Foundation, ELMCOR, and a whole bunch of other people, including the World Health Organization, that are out there putting the time and effort into this. But think about that $7 a person number. So if everybody in this room, everybody in Newton, everybody in the United States gave up a cup of coffee once in a while and put it into this, money is what makes the difference here. And so it is making a difference. People are doing that. So it's something that each one of you could do and take credit for and feel good about. Okay, next slide. So 627,000 deaths a year. And it's essentially eradicated, as you saw, from North America, Europe, and Russia, and the tropics. So what does 627,000 deaths a year mean? Anybody know the population of the city of Boston? Very close, 98.5% of the population. Next slide, please. So imagine that. This would be as if every year, not this year, but every year for decades, the entire city of Boston died. And then was replaced by another group. And then they died and was replaced by another group. That's what's going on in the world. The difference is, this number is actually probably half, according to that, and according to what I looked up, of what it used to be 10 years ago. So it's better. You're saving, for every 627,000 people who are dying, you're saving 627,000 just by putting your money in a hard. Next slide. So where is it in the world now? Next slide. So that's depressing. It's everywhere, right? Almost. Next slide. And here it is in the Western Hemisphere. Okay, so let's forget it. You can't possibly wipe it out. Yeah, you can reduce the numbers, but you can't make that big of a difference, right? Next slide. So this is a World Health Organization map from between 2000 and 2012. Everywhere that you see green is a place where malaria has decreased in numbers. So look at how much of the world is better off as a result of that. Now there's a slide at the end, if I remember the number correctly, it's like 20 of the 97 countries that are still listed as having malaria have almost wiped it out. So someday, these places, you know, think of all the World War II movies you've seen, because you're probably all about the age of me, you know, where the guy gets the fever because he's in Africa, or, you know, he's in China, or he's somebody, you know, or he's in Vietnam. Think about all that stuff. Where if I say Vietnam and I say, what disease are you, I'm immediately going to say malaria. What's practically going on there? That's what this map means. So the only places where for sure it's increasing is there in poor Haiti, and then these brownish areas are because there's, quote, insufficient data. Now, insufficient data may well mean that it's getting worse. I can't tell you. All I can tell you is in Malawi, I sure see a lot of it, and it's an awful disease. Next slide. So you all lived in there, so I won't bore you with the second starfish story. One of my favorite stories. Next slide. Okay. Now, I'm going to blow through these real fast unless you guys really want to know the science behind what causes it and how it works. This is actually just so you can be impressed by the level of the high school kids. The deal that I do with them is they sign up for this program, and they're in Hudson, Neshoba, which is Walthamstow, and Lancaster, and then Marlborough High School. And to some extent Harvard, which goes in now. Sometimes they answer my phone calls and sometimes they don't. So I give them 3 hours of lecture at a medical school level on tropical diseases. And then there's a Malawian-born medical student who gives them 3 hours of lecture in Malawi. We used to do this on Nicaragua. We had a Nicaraguan-born American who gave it in Spanish on Nicaragua. So it's actually a little easier now than it used to be. At the end of that second set of lectures, we do some 2 successive weekends. They're given a multiple choice test. Whoever gets the highest score gets to go with a medical mission trip for free. That's where this all started. So I was going to go anyway. I was taking medical students and doctors and nurses with me, but I wanted to bring my kids someday, and so I thought, wouldn't it be cool if I brought other people's kids, because mine are too young. So originally, the cost was out of my pocket, and then some people talked me into trying to talk other people out of money, and I thought, I can't do that. I've learned to be reasonably good at it. So it's taken a little while, but the reason I've learned that is not so much about me, it's that I found that people actually have really good hearts. And if you present them with an opportunity to do some good, and you convince them that the good is not going to go to administrative costs or something that is fraudulent, but they actually really want to help. So one thing I'll tell you about my program is there are no administrative costs. If an administrative cost comes up, I pay for it out of my own pocket. So if I get money from some other organization like the Lions Clubs where we live, or some of the local doctors and nurses, that money usually goes directly to whatever we're doing in Africa. And I don't take a salary, neither does anybody else, and we pay for our own airfare. We just pay for all of that stuff. So this is all about just making sure the money goes where it should. So, the genus Plasmodium. So what is the thing that causes malaria? It's a protozoa. It's kind of like an amoeba almost. So if you can imagine an amoeba, instead of being in the river somewhere, pitching a riding mosquito, getting injected into your bloodstream where it does bad things to you, and then getting sucked back up by another mosquito and moving on to the next person, that's basically what you're talking about. So there are 4+ species. The only reason that this is important is this one is a killer. These make you sick. And if any of you ever think about sending any of your relatives, or if you want to go to medical school, I can tell you one of the rules in medical school is, for the test, if they ask you, which one of these is the most common cause of malaria, never pick the one with the disease name. I don't know why that is. It's probably just the first one that they found, but it's not the most common one. But they'd love to ask that question on the test. Okay. How do you get affected by Plasmodium? As I said, next slide. Okay. Transmitted by the bite of a female, not not a male, Anopheles mosquito. So how do you tell the difference? I understand the best way to tell the difference is the males don't bite you. So if you're being bitten by a mosquito and it happens to be this particular species, then it's probably a female. Okay? Now, wait a second, go back. Anybody in this room know who Walter Reed was? Yeah? A couple of you, right? Okay. Me too. Any of you know who Ronald Ross was? Yeah, he got screwed. So Ronald Ross is the thread that figured out that mosquitoes carry malaria in India. And I think he did it before Walter Reed figured out yellow fever. But nobody in America knows his name. I didn't know who he was. I had to look him up. Next slide. Okay. So there is a female Anopheles mosquito. You can tell by the Victoria's Secret underwear she's wearing. And this is a blood smear of somebody that has malaria. So these are normal red blood cells. They basically should look boring, like there's nothing inside them. So any place where you see a purplish thing, whether it's a little purplish thing like that, or a bigger purplish thing, or a whole bunch of big purplish things, that's malaria parasite inside the red blood cell. And one of the main ways, probably the main way, that malaria gets you is by what it does in your blood. So it causes anemia, whether it's the big bad falciparum, the really nasty one that kills people, or the others. This is what it does. It destroys red blood cells. So it's merrily reproducing. So the reason there's so much there is that it starts out with just one little protozoan that goes in there, and then it starts to eat the hemoglobin and reproduce itself. So it's a wonderful place if you're a parasite. It has a ball in there, but it's really bad if you're the host. Next slide. Okay, so what does it do to you? Short answer, next slide. It does that. So this is one of many children that we took care of, and about 2/3 of them died. So this kid is suffering from what's called cerebral malaria. So let me stop there and just explain, why. Why do these kids die? Why do they come in looking this sick? So you have to imagine yourself as living on a farm in Malawi. Now, when the Sandinistas took over Nicaragua, they did land reform. So they made sure that every poor farmer had a subsistence plot of land that they owned so they could feed their family. And the result of that is that when we were there, we'd have a debate about whether a kid was malnourished or not. And basically that debate was about what color their hair was, because protein malnutrition, which is called kwashiorkor, gives you reddish hair. So if we saw a kid with reddish hair, we'd say, what do you think? Does he look kind of thin to you? And this is what it was like. In Malawi, you see kids just like the ones on television, with the big bellies and the ribs sticking out, who are obviously malnourished. So the difference is, in Malawi, very few people own the land. There's a lot of sharecropping, and sharecropping and tenant farming means you've got to pay the landlord with crops before you can feed your family. So the result of that is malnutrition. People that really can barely afford to live, and they're just right on the edge. So if you're that farmer, and by that I mean the wife and the husband, because they're both farmers, and you have the duties of taking care of that farm, and the kids, and the livestock, and everything else, all divided between the two of you, what do you do if the kid gets sick? You hope that the kid doesn't get sicker, that the kid gets better. That's what you do. You got no 911, you got no cell phone. You may, if you're lucky, live on a dirt road that might be passable if it's the right time of year, as opposed to being in the middle of a flood like there is in southern Malawi right now. But even more complicated than that, hospitals in the third world, because they did this in Nicaragua too, they provide medical care. Now, when I say that word to you, guys think, okay, so the person's going to get fed, the mother's going to get done. Not there. They provide medical care. So some relative, usually a female, often the mother or an aunt or a grandmother, has to drop what they're doing and go to the hospital and feed that person who's there and sick in the hospital. They have to make meals, they have to do laundry, they have to do a lot of things. And if this place is hours away from where they live, they're not going to commute back and forth. So you're making a desperate decision here when you decide that kid is sick enough. It's a choice that you have you can't make that choice. You're stuck now because that kid has to be so terribly sick that you can't ignore it anymore. Because if you choose to ignore it as the kid gets sicker, it's because you have to be able to keep the farm functioning. You've got to be able to feed the family, which you're barely being able to do. So it's a really awful choice. And the result of that is when the kids come in, they're this sick. So the solution to this problem, which we'll talk about a little bit later, is to try to make sure that there are people in the countryside in every village who know how to take care of this problem. Figure out if somebody's got malaria and diagnose it and treat them right there. Before we even talk about doctors, nurses, and hospitals. And that's actually being done. And the better treatment is to prevent it. So UMCOR is working along all those lines. We're working along we bring supplies and our knowledge and techniques to the hospital with us, but I'll tell you, it doesn't matter whether it's an American doing ICU care or it's the Malawi's and the traditional stuff, and we do have some disagreements about how to take care of it, they just die. They either live or they die. It doesn't matter what we do. The only thing that makes a difference is quinine, which is what they use when these really sick kids, because you've got to kill the malaria parasite. If you're lucky enough to bring it back from the edge, that's how you do it. Next slide. But this is also what it does to you. See how healthy these people look? So this is the waiting room outside the hospital. So these are the very relatives I just told you about, who are cooking and cleaning for the patients inside. And they spend their day out there talking and chattering away. I don't actually know where they sleep, but I think they do sleep out there as well. And part of the reason that some of them are happy, this is also the waiting room for the maternity ward. Lots of spaces more in this hospital. And this is part of the hospital right there. So what's the difference? There is this concept in medicine where you can be infected with something, which means it's inside you, but it doesn't make you sick. That's called an infection. Or you can be sick from it. That's called a disease. So when you see this number that 1 billion people are infected, that means that all these people can have a parasite in them, but they're not pregnant. They're not little kids. They have relatively good immune systems, and most likely this is not the first time that they've been infected with malaria. So their bodies can either get rid of the parasite completely, or bring it down to a level where they and the parasite can live in harmony. And that's what a parasite wants. It doesn't want to kill you off. It wants to be able to suck your blood for a really long time. Next slide. Okay, next slide. So if you were a parasite, what would you do? Get inside a host and kill it within a couple of minutes? That's why Ebola doesn't spread. Because it gets in, and it does somebody in pretty quickly, and they don't have a chance to, as much as the news media make it sound like, oh my God, everybody's going to get it, it doesn't work like that. And let me just stop and say a word about that. Ebola is a horrible disease. It's certainly not something that anybody should get. It's something that needs to be wiped out in Africa. But I was just asking John Connor, who's a specialist in it, the numbers for Ebola infection, 12,000. 1 billion. Deaths, 5,000. And that's just this year. 627,000 every year. Last year, deaths from Ebola, practically zero. So, and why does the news media not talk about malaria? Because they're making you all think you can't do anything about it, so why talk about it? Next slide. Okay, so the perfect parasite-host relationship is just enough. It's like the vampire that keeps the body in the basement, you know? I'm just going to keep sucking your blood forever. Yes, sir?
Just a question about that this is not a virus that where you can develop antibodies that can attack the virus if it doesn't kill you. This is a different.
Well, this is a protozoan. So
Protozoan.
viruses are tiny. This is a big mother when you think about it that way. But you do make some antibodies against it. Actually, genetically speaking, the things that are really interesting about malaria are that sickle cell and thalassemia, which gives you itty-bitty red blood cells. A lot of people from the Mediterranean basin have that, and people from Southeast Asia have it too. And something called G6PD deficiency, which is a particular enzyme that people from this area have. All three of those things give you a certain amount of resistance to malaria. So sickle cell, which is an awful disease to have in the United States, actually was a good thing to have in certain parts of Africa because it protected you from malaria. Next slide. Okay, I mentioned this, sick versus not sick, infections versus disease. Next slide. Okay, so are you ready for the medical school level talk? Everybody take a deep breath. So part of what is complicated about learning about this is that as a protozoa, it has this really interesting capacity to change its form. So it's almost as you go through this, what happened was the scientists said, okay, with a microscope, said, oh, this one's a this one's a that. So that's why the name keeps changing. So it's a little bit as if it went from being a male to a female, to a dog, to a cow, to a horse, and then back again. That's kind of what it does. Okay? So this is a CDC slide. If any of you don't remember the lecture and you want to learn about this, or Ebola or anything else, the CDC's got wonderful websites. Basically what happens is the malaria parasite is in this mosquito because it bit somebody, because that's where it comes from. It bites this person gets infected, and the person can actually give it to the baby, which is extremely rare. Viruses are easy to pass through the placenta, but the parasite's very big, so it doesn't happen very often. Goes into the liver. That's where the infection begins. But when it's in the liver, it doesn't tend to make you sick. So the liver cells, same thing. The parasite invades a cell, starts to reproduce in there. Eventually the cell bursts open, the parasites are loosened into the bloodstream, and then they go for a ride, and this is what they do next. They start chewing in the red blood cells. And eventually, some other mosquito comes along and bites you, and then takes up some of the parasite because it's sucking blood, the parasite's in the bloodstream, it's in the red blood cells, and then it moves on to bite the next person, and that's just how it goes over and over again. Next slide. Okay, so I won't make any of you memorize this for the test. Next slide. I had to memorize it for a test. Next slide. So you asked about what happens. So once the liver cells burst, you start to feel sick. And what you get is a fever, nausea. You feel like you have the flu, basically, except it's bad flu. You feel really bad, right? Correct me if I say anything wrong, because I haven't had the pleasure, I've only seen it in other people. Next slide. This is only important, I love the name, just because when you treat malaria nowadays, you give certain kinds of medications that kill the parasite inside the bloodstream, but it doesn't kill them if they're in the liver. So there are certain kinds of malaria, this one and this one, that actually can lie dormant in the liver without making people sick, and then reoccur years later. Next slide. And there's a particular kind of medicine. If you know that that's the species, there's actually a kind of medicine to give the patient to kill the stuff in the liver too. Next slide. So those of you that are old enough, again, probably watched at least one movie where, how do they know it was malaria? Because of the periodic fever. So you get the flu, you get pneumonia, you get whatever it is. How does the fever work? Well, you get the fever, and it's pretty much there until it goes away, right? Every day, day after day. Because of the way this works, where the liver cells basically sort of burst open at the same time, the parasite's released into the bloodstream, and then it gets into the red blood cells and starts to multiply, kind of all at the same time. There becomes this periodic thing where there are bursts of parasites, and then a couple of days will go by because the parasites are reproducing inside the cell, but they're not where your immune system can see them. And the result of that is for a couple of days, you don't feel so bad. And then burst, and the fever comes back again. So for certain, for everything but Plasmodium malariae, it's a 48-hour proposition. For Plasmodium malariae, it's 72 hours. So if you ever find yourself without a doctor, without a test, and all of a sudden you got this weird fever that comes every 3 days, you probably got malaria. There's almost nothing else that does that. Next slide. Okay, next slide. We'll just keep on going. Next slide. Okay, so now you're sick. So this is the disease, okay? You've had the protozoans in you, but you're not sick. It's just called the infection. So what happens to you? You start out with this high fever that's a daily proposition, but eventually becomes periodic. Your spleen and your liver get big. Why? Because that's where you filter things that is bad for your body. That's where lots of antibodies get made. That's where a lot of infection stuff gets fought out. And so the spleen and liver get big because you're using it more. And because of that, it's like any factory. If you've got more work to do, you hire more guys to do the job. Next slide. Okay, so this basically just describes what it feels like. 40 degrees centigrade is up there. Talking 103, 104. I can't remember the exact number. Do you remember the exact number? But it's up there. So it's a high fever, and you get the synchronicity to it. As I said, sickle cell, thalassemia, G6PD are all things that protect you. Next slide. So the first symptoms are you feel like you have the flu. Oh, go back. And then later on, you get this regular fever with the big spleen and the big liver. Next slide. Okay. So, are you going to survive? Well, there's our example. He's still here, right? If you're an adult, yes, it's likely that you will. This is a killer, and if you don't have falciparum. So falciparum is the killer. It's a killer of young children, 6 and under in general, and pregnant women. And the reason for that is their immune systems are not as good. Now, when I say that, that's a broad categorization, but you have to add a couple of other things in. If you're well nourished and you're 6 years old in the United States, or you're well nourished and you're pregnant in the United States, and you were to get malaria, you probably would do a lot better with it than if you were terribly malnourished. Because malnutrition is bad for your immune system. So it's a bad combination. Next slide. Okay, so young children, pregnant women. Next slide. Also, if you come from the United States, if you've been multi-generations here, nobody in your family's had malaria for a very long time, there is this herd immunity thing that you're probably hearing about with measles right now. So it does increase the chance that you'll get sicker from it. Okay, so the worst form of malaria is this, from this disease, cerebral malaria. Kids come in comatose, they can seize. Look at the mortality rates. Mortality means who dies from it. 20%, so 1 out of every 5 adults, 1 out of every 3 children. In Malawi, the rate is much higher than that. Probably 2 out of every 3 kids that we saw there died from that. And if you survive, this is what's left, especially in the little kids. Now, that's horrible, but in America, there are C9 dogs, there are handicap ramps, there's all this stuff that helps disabled people do well. In third world countries, none of that exists. So if this happens to you or to your kid, they're screwed for life. Next slide. Okay, so why bother? We're back to the why bother. Look at that. Treat it, and that's the mortality rate. So 1 in 1,000, as opposed to 1 in 5 for adults, 1 in 3 for little kids. And the treatment doesn't cost a lot. This is all about believing that it makes a difference in getting the treatment to where it needs to go. Next slide. So how does it kill? Next slide. So this is the medical school stuff. I think it's kind of cool, and from a disease point of view, so I'm just going to mention it very briefly. What falciparum does is it hides from the immune system. And it does that by making the red blood cells that it's infecting stick to each other. The other kinds don't do that. So the red cells are still just narrowly going through your bloodstream, and your spleen and your liver are designed to notice if a red blood cell is not normal. And so if it notices that the parasite's there, it goes home. And that's the end of that red blood cell and the parasites as well. And you're done with the infection, or at least you've got it down to a level where your body can survive. But if the infected areas, if the infected red cells never get to your spleen or your liver, then your immune system can't get to them. And so not only does it make them sticky, but the other part of this is when they get stick together, you get little blood clots, which plug up blood vessels, and that's not a good thing to any of your organs. And unfortunately, there's a predilection for this to happen in the brain, which is why there's coma and seizures and things like that. Next slide. Next slide. So the hiding the body's immune system called sequestration. Next slide. Okay. So mild case of malaria from one of the other non-falciparum kinds, you get mild anemia. So what does that mean? It means you're dragging your butt all day long because you're anemic. You don't feel good. Lots of women in the crowd, I'm sure some of you have probably had that experience just from menstrual flow. But it's much more common in the third world. Bad anemia means that you might be down to 10% of the red blood cells that you should normally have. It's amazing the numbers we see in these little kids when they come in. So they're really delighted to see us in Africa when we get off the plane because they look at us and say, fresh blood. We all give blood over there. Next slide. It's kind of cool to see your blood going into somebody. Some spirits you don't have here when you donate, but we need to see it. So it's a huge cost to society and the healthcare system. That's why it's bad for the country, because not only does it kill your future, but also the ones it doesn't kill, even the grown-ups, they're just not going to have the energy. So because they're not really well all the time. Next slide. Okay, it kills little kids, it kills pregnant women. It causes premature birth, which kills a lot of kids too. And it can cause chronic disabilities and anemia. Next slide. And incidentally, the way the government hospitals in Malawi work, this is how well-to-do this country is. It's the 11th, or it's somewhere in the 11th poorest country in the world. The government hospital gets a month's supply of medications. It's gone in 2 weeks. So if you're there in the last 2 weeks and you're sick, you're screwed. You have to go to another hospital. Because there are some semi-private ones that are supported by various churches and NGOs and places like that. Next slide. So, what do you do about this? Well, if you imagine that everybody in this room is okay except for one person who has malaria, and there's one mosquito in this room, how long do you think it would take for that mosquito to get around and get all of you? Take a long time. So the more people in the room that you have that have malaria, if half of us did and half of us didn't, that mosquito will probably still take a long time to affect the others, but it's going to have a greater chance of biting somebody that has the malaria and more likely therefore to transmit it. So now if we increase the mosquito population, then everybody's kind of done for, right? So epidemiology, which is the study of how diseases get transmitted and occur, that's basically the deal here. The more mosquitoes there are, the more people that are infected, the more likely it is that somebody's going to get malaria. So you fix this problem by working in reverse. You're not going to remove the people from the area because they live there. But what you can do is try to reduce the number of mosquitoes and the kind of the exposure to mosquitoes. Next slide. Okay, and then there's this. Fix these three things, and you can wipe out a lot of disease, both here and in the rest of the world. Next slide. Next slide. So this is a rural clinic. It's 3.5 hours from the hospital that we work in by dirt road, which was passable that particular day because the rainy season wasn't quite so bad that year. We saw 700 people, all inside this building. There's no HIPAA. It was sitting literally just like you guys are. So we'd be talking to one person, the healthcare provider next, we'd be talking to somebody else. And one of the things that can be done in a place like this is education, which Peter Manjali, who's the chief medical officer for the hospital, he's right there, is giving a talk on, it might have been on malaria, I can't say exactly what, but it's disease related, and these are things that you, as people who live in this area, can do to try to prevent getting sick. If you notice, this is kind of standard wear there. not really good in the place where you can get a mosquito-ridden disease, right? But it's hot, it's humid there, and I have no idea how hot and humid because there's no daily weather report. It's probably in the 80s most of the time, and humidity is probably close to 100%. So, when you go out to do something like this, you want to try to talk to these people and educate them as best you can. I was asked to give a talk on just simple hand washing, and the first thing I said to Peter when he dumped that on me and said, guess what, you're going to give a talk right now, was, can these people afford soap? Because it doesn't make a lot of sense to be telling somebody to do something that's totally ridiculous as far as they're concerned. The answer I got was yes, they can. So I have no idea what I said because he translated it all into Chichewa, which is the local language, but hopefully this is of some value. Next slide.
When he said that this clinic is 3.5 hours from the nearest hospital, that's 3.5 hours by one of the vehicles that are driving.
Right.
These people don't have those kind of vehicles.
Yeah, so it's probably closer
You
to
know,
12
so
hours.
it'll take
by
them
foot.
a day and a half to walk there with a sick child. So they're gonna wait till the last minute.
Yep.
To make sure that that kid's really not gonna get better by himself before they leave.
Okay, so how do you wipe it out? Prevent it and treat it. So the key for the treatment is, since getting people to the hospital is so difficult, since they're so sick when they get there, and since the treatment only saves a certain percentage of them, you want to treat it when it's out in the countryside. So how do you do that? You have to completely erase the idea that doctors and nurses are involved in this concept. Okay? So it would mean if each one of you were from a different village, each one of you was designated by the village or by yourself as being the healthcare provider for that village, we would teach you what are the symptoms of malaria. We might give you some testing material, because there's a way of doing the pinprick testing right there and then knowing whether a person has malaria and if so, what kind. And give you the medicines and say, if you're sure, you go ahead and treat this person. Because the downside is very low. And the upside is, then you're keeping these people from never getting so sick that they're going to die. Because remember that number, 1 in 1,000 die from properly treated fell sick with them. So almost everybody actually does pretty well. And the more people you treat, again, the less disease there is. But that's not the solution. That's the solution. That's why we don't have it in the United States. Because the government wiped out the mosquitoes. They drained swamplands. All the things you hear people argue about wetlands now, it wasn't an issue back in 1882. They just drained stuff. And back when they could afford, when they could come up with DDT and low chemicals like that, that's why they used it. It was to kill those mosquitoes so that we wouldn't have diseases, mosquito-borne diseases like this. Next slide. So how do you do it nowadays? First of all, you have to teach people what the problem is. Second, you have to use nets and screens. Screens are unheard of there. Even the healthcare providers who are relatively middle class and whose houses we stay in, they don't have screens. I'm going to bring this to this here. And their kids get malaria. The nets are wonderful. The nets have issues. So you're a poor fisherman, you have 7 kids and a wife to feed, and somebody gives you a brand new beautiful net. What are you going to do with it? You're going to fish with it, right? And actually the same thing applies if your livestock is wandering. I've given you a net that somehow will keep the livestock from wandering. You're going to use it for that. So the wonderful thing is that the studies say that at least 60% of the time the nets are used for the proper reason, as opposed to never. But that's the problem with nets, is that it's not a perfect solution. But a good deal of what you see when the numbers are dropped in half over 10 years is because of those nets. They're impregnated with mosquito repellent. And what they do is they're not walking around inside all day long. Since the mosquitoes are mostly dawn and sunset, that's when the nets are used. So it's something you drape over your bed and you sleep under. And believe me, we do that when we're there. And in the hospital, they have mosquito netting too. So that's the first thing. In the U.S., mosquito repellent, not an option there. Vaccination, not an option. It's the holy grail of malaria. But when you're making a vaccine against the virus, you're dealing with a very little thing that stays kind of the same. And one of the reasons that there's no vaccine against HIV is it keeps changing. The malaria protozoa is a big thing, and it changes. It goes through all of those different names that you just saw, the merozytes and the sporozytes and the this site and the that site. And so you have to be able to have a vaccine that kill every single form of it, and there is no such thing right now. So that leaves you these two. I love the fact, I didn't coin this, but this is what the Africans call it. So I'm for the IRS, and you should be too. So this is a brilliant idea that came up just in the last few years. Some countries in the world, malaria is a seasonal thing. When there's a rainy season for 3 months, that's when the mosquitoes are there, that's when you're going to get it, and that's when you're going to get the disease. And the other 9 months, it's not an issue. So there's a pill that you can give somebody, and again, the number's about $7 a person, that lasts for a month. So all you got to do is have a logistical way to go out into the countryside or in the cities and give a person 3 pills. And maybe you only do it, one per month, but you go out 3 times. And you do that, you're preventing them from getting malaria during the season. Now, I thought that was a brilliant idea, so I got really, I have a personal vendetta against malaria because I can't stand to see anybody die from anything, but it's really hard to watch these little kids die. So I came back and I called Peter up and I said, because I could Skype him in Africa, which is cool. I said, I'm totally out of money for bridges, but I've got some money of my own. I've got $3,000 I'm willing to, to put in you doing this. And he got back in touch with me by email and said, the government won't let us do that because even though where we are, it's seasonal. Where the lake is, it's 24/7 around the clock all year long. And the lake is a big part of the Malawi coastline. So the World Health Organization has decided, and the other one's telling the Malawi government, we're going to do this country by country, not region by region, not state by state, not district by district, but country by country. So there are some countries they won't do it in because it's not seasonal. So Peter's idea was this, the IRS. So that's why I'm in favor of it. So that's where the money went, $1.50 per person. So what does that mean? They spray inside the houses. The stuff lasts for months, so they only have to do it twice a year. And it's a contact killer of mosquitoes. So when a mosquito lands on the wall, it kills it right away. Now, none of you being Americans, and me too, would probably want any insecticide that lasts that long sprayed on the inside of your houses. So my very first question was, is this stuff safe? Well, when you look it up, it's not the safest thing in the world, but it is what the World Health Organization recommends. And not the safest thing in the world means there are laboratory data that suggest that it can cause birth defects, it can cause cancer. There's never been studied in humans, so nobody really knows. It's not great for the environment if it gets loosened out into the streams and lakes. So, but the other side of it is, if you had to make this decision, and I told you there was a 100% chance of at least one of your 6 children dying from malaria, or maybe a 1 in a million chance that one of the kids might have birth defects, what are you going to say? And the truth is, when I had to make this decision to agree to do this, I thought, what I do every day as a doctor. I give people pills. I know they have side effects. I make this decision either consciously or subconsciously, constantly. So we went for it. The deal we have with Peter is that he has to prove to us that it works. In Blantyre in the south, which is where all the flooding is right now, there's a huge NGO that's been doing a lot of spraying in a large area. And they have statistics that show that it's reduced the mortality rate and the infection rate by 2/3. That's pretty good for $1.50 per person. So, as you might expect, as soon as we did this, the chiefs from the next 2 villages over said, what about us? So I then went to my friend, the orthopedist, Don Hangen, who is also part of their nonprofit, and said, it's your turn, Don, you're an orthopedist, to make more than I do anyway. So, and then I went back to my own pockets, and and so between the 2 of us and some fundraising we've done, we've now put probably $9,000 into it. So we've now sprayed, they're in the process of spraying the 3rd village right now. For the first time. The first village has now been done twice. And the deal we have with Peter is he has to prove to us with statistics that it made a difference, but I'm assuming that it will. So where I started with all of this was, I'm a doctor, I wanted to be a Peace Corps doctor, it didn't work out because her predecessor had no interest in doing that. Cindy would have lived with me in Nicaragua the first time we went there in a heartbeat, so I got the right woman now. But I was just going to go, practice medicine, do whatever I could to help, bring as much stuff as I could, and somehow now I'm spraying in large areas of villages. So I went from thinking that I was going to make this huge difference, to realizing that what really makes a difference is not a single doctor or a single healthcare provider, it's public health. And it's also very small amounts of money that make a huge difference. Next slide. Okay, so the other things, as I said, you improve access to healthcare, and you do that by getting the local malaria treaters. And you give that person a cell phone, because they do have cell phone coverage in some parts of Malawi. So that person can call the hospital and say, I'm the village guy, we have this one kid, this kid is getting sicker. When do I make that decision that the kid has to come to the hospital? And they can talk about it, as opposed to the parents that have no clue, except that they know their kid's getting sicker and they're willing to do that. Next slide.
You just said that person would say, I'm the village doc.
No, the village.
Village guy.
The village
Oh,
guy.
the village guy, I thought you said doc. Whoa.
Next slide. This is the other thing you can do. Pray. So it's kind of funny that Doug had me go stand up in front of the church because this is a routine thing. The first time I did this in Nicaragua, it was like, okay. just, you know, and that day they didn't even tell me. We were just going to church just to see what it was like. So I had a pair of scrubs on. So I really felt embarrassed, and they were so gracious and so nice. And when we were walking to that church, I can still remember, they were singing this tune in Spanish. We could hear it. The church was up on the hill, we were down in the valley, and as I got closer, I said, I know that tune. It doesn't sound like something you'd be singing in the church. They were singing the Battle Hymn of the Republic in Spanish.
Because you were coming. Do something.
So any of you heard the music that I was playing? These people rock the joint. It's all a cappella singing. They're in a place that's maybe a little bit bigger than this room, 300 people. And when they get to singing, you feel like God is really there. And considering what Malawi is like, God needs to be there, and they really need to believe it. Next slide. Okay, so this is just about how different treatments are required for different kinds of malaria parasites in different parts of the world, because there's some resistance. Next slide. Okay, age, weight, and pregnancy. Some drugs you can use in a pregnant woman, some you can't. Next slide. So here's just a small list of drugs. I would particularly point out to any of you that are considering going to the third world. What I tell the high school kids is anything that has a quin in it, that's a malaria drug. But the problem with the quins is they can make some people really nuts. When you take it, one of the side effects is it can make you anxious, it can make you hallucinate. I've seen all of that in traveling with docs and medical students in Nicaragua and Malawi. And I know it makes me anxious. So what I do is I take doxycycline. So my acne gets better, and I don't get malaria, and I also don't get traveler's diarrhea all at the same time.
Taking medicine.
Yes?
He's had really bad acne.
Use it in combination with treating it, but as a preventive, doxycycline is used by itself. Next slide. Okay. So I mentioned that briefly. Next slide. So another kid that died. Next slide. So this is just to illustrate what I've been talking about. These are statistics from the Kisumu District Hospital, which is a government hospital that's up the road from the hospital we work in. We're actually working in the district hospital too, so that the people I bring will have a chance to experience both what the government hospitals are like, which are much bigger, and what the semi-private hospital that's run by the Episcopal Archdiocese in the area is like. So they have the strangest thing there, because they don't feed the patients, they don't do laundry. If the patient can't afford to pay the bill in the semi-private hospital, you know what they do? They keep them there. It's the exact opposite of what happens in America. It's so counterintuitive. They never want to go home until somebody pays the bill. And so they tell us that there's a sliding scale. They actually know who can afford to pay and who should get free care. So I don't know how they do that, but it's a little bit, I'm uncomfortable with it, but I can understand it if they just gave it all for free. It would be like the government hospitals, and people would end up with no treatment. So it's a dilemma that I don't have a solution for. Anyway, this is 10 common causes of deaths in the female ward in December 2013. Malaria is right there, with 18% of deaths. Pneumonia is a big one, and anemia is 19%, but I'm not sure what the cause of anemia is. It might be AIDS or it could be malaria. Next slide. Okay. 10% common cause of hospital admissions female ward. Malaria is the big winner there. Next slide. This is male ward. Malaria, 34%. That's cause for admission. This is cause for deaths. There's malaria down there. So you can see it's a big problem. Next slide. So this is a pediatric ward at St. Andrews. When it's really full, how do they handle the problem? Mom and a kid, mom and a kid. They literally divide these little crib-like beds up into two halves. And then the people live on the floor after that. There's a mosquito net right there. So they put them on the patients at night when the sun's going out. Because there are no screens on the windows. At least what passes for a screen here doesn't stop mosquitoes from getting in. Next slide. So, this picture. This is at the rural clinic. I'm going to end with this picture. I'm almost done. For those of you who are getting antsy, you're going to have to go deal with the snow like we do. But I want you to imagine that there's a kid's face, or there should be a kid's face in every single hole there. The reason there isn't is because of malaria. So part of what you can do, whether you give money to UMCOR, or you give it to Bridges to Malawi, which is our organization, or any other way that you want to do this, and you can use other diseases and other reasons for why these holes are not filled. But think about it this way. You're putting a kid's face back in one of those holes by doing it. And it's going to cost you $7 to do that. Next slide. So this is one of the high school kids we bring along. She's actually with a Canadian nursing student getting ready to test somebody. So all you do is prick the finger and they put in a little petri dish-like thing that's very small and it tells you right away if the person's got malaria. Next slide. This is a preemie who was sufficiently premature to be able to not be able to feed itself. So this is not a bad preemie. My wife is a labor and delivery nurse, and she will tell you that looking at that kid, you know, by American standards, this kid should have done really well. And this kid died that night. That's Mariah, by the way. My stepdaughter is a nursing student. She's going back again this year. Next slide. So this is Peter Manjali in his white coat. There's the mosquito net. And there's the overflow patients on the floor.